everybody. My name is Amelia Pousson. I'm faculty at Johns Hopkins, where I have the great privilege to work with fabulous trainees. Many of them know, but not all the audience knows, I'm a nocturnist because the light of the sun burns me. I also have the great good fortune to have worked in places other than Baltimore in my career, and I work predominantly as a medical educator. So that's what lights me on fire. One of the things that we know about how adults learn is that we learn by telling one another stories. So I hope you guys will bear with me if I tell you a couple of stories today. So I'm going to tell you stories about three men, okay? Paulin, Robert, and Faustin. I've been told that my accent speaking French can make francophone ears actually bleed, so please forgive me as I massacre these poor men's names. This story is going to take place in East Africa, because that's where the real people who inspired these stories are from. But it could be the story of a lot of different places. I started working in resource-constrained settings, not in sub-Saharan Africa. And when I moved to sub-Saharan Africa to help lead residency training efforts, what I was told by colleagues who'd worked there for years, is that patients who showed up in decompensated shock universally died. That when a patient had reached the state of decompensated shock, that I shouldn't be putting my limited efforts around spending educational time with my trainees, my limited efforts around the resources that I had, my limited efforts around trying to get my nurses to do reassessments, trying to get my nurses to triage these patients accurately. All of that stuff did not make sense to do because these patients, their outcomes were foreordained, right? That there was no way to save these patients with the systems and the stuff and the staff that we had. And so I hope that when you leave this lecture today, and I'm only going to talk for just a couple minutes, that I will maybe put a little doubt in your head about what my colleagues told me. So we're going to start by talking about Paulin. So Paulin, like many young men, is a motorcycle taxi driver, okay? And he works in a big city where this is the main way where working class people get around. They get a moto taxi, okay? He was crossing an intersection, and yes, he did have the right of way, but he was hit by a pickup truck. And as a consequence of that, he had an open femur fracture and a pelvic fracture with heavy blood loss on the scene. By the time he gets to your emergency department, he's in overt hemorrhagic shock. He's diaphoretic, he's pallorous, he's thirsty, he's flailing, he's tachycardic to the 130s, and he's hypotensive. You have a fabulous nurse working with you, and they do a blood pressure. It's 70s over palp. So what happens? Well, when Paulin comes to my emergency department in the middle of the night in Baltimore, and somebody very much like him comes to my emergency department on the regular, he gets transported by EMS. He gets a trauma activation. There's like 20 people in the room with me, some of whom I've never seen before. He has CT imaging completed of everything within about 15 minutes of his trauma actually happening, because I live in a city that's not geographically very big. Pre-hospital, he's had a commercial binder applied to his pelvis. It's been applied correctly. He has a hair traction splint on. And then orthopedic surgery. A specialist surgeon sees him in the emergency department in the middle of the night, places an anesthetized transtibial traction pin. He's in hemorrhagic shock. He gets blood. He doesn't have to have a family donate blood. He gets blood now because he needs it now. And he goes to the OR even if he doesn't have an ability to pay. Now, his chance of disability-free survival is very likely. In contrast, there we go, what actually happened to Paulin. So he got bystander transport, okay, which is definitely better than nothing. He got evaluated by an emergency medicine trained physician and a nurse who did not have trauma training, but who had the soul of an emergency nurse, right, who wanted to do right by these critically injured patients. And all of that happened within the golden hour, okay, because Kigali's also a pretty small city. He got plain film imaging and an improvised bonder, as well as a traction splint followed by casting with a window over the open area of his fracture the next day. He got limited transfusion, so a single unit of blood, which is probably less than he needed, and his family needed to replace that unit that was given, right? And he may, had he not been somebody who had a pretty good job, moto taxi drivers make pretty good money, have had his treatment denied if he went to a different kind of a facility or a facility that didn't do some form of a wallet biopsy at the door. So his survival is likely if there's some degree of EM systems in place, but he may have a disability. He's not getting what we would consider ideal care for his shock. And those of us who have worked in resource-constrained settings probably see a few things in our Kigali eval that are movable, stuff that we can change even without spending a ton of money. Let's go forward to Robert's story. So he's 65, he's a former miner. He mined in South Africa and then came back to Kigali to retire. He has chronic cough and lung disease, doesn't have more details about it than that, and he collapsed, okay? His spouse comes with him and says he's been febrile and coughing much more the past week, and we presume that he has pulmonary septic shock when we evaluate him. He's delirious, he's flailing, he's febrile, he's tachypnic to 40 breaths a minute, hypoxemic, 88% on room air. We shoot a chest x-ray and we see he's got a big infiltrate and an effusion. He's tachycardic and he's decompensated. He's hypotensive to 60s over 20s. In Baltimore, he gets blood cultures sent and resulted by 24 hours. We know that it's strep pneumo because there's rapid antigen testing done on it. He gets his sepsis resuscitation tracked with a variety of forms of point-of-care ultrasound. He gets an A-line, he gets serial ABGs, he gets serial lactates, he gets 30 cc's per kilo of crystalloid, he gets broad-spectrum antibiotics within an hour of hitting the door of my emergency department. And then when his shock is persistent, he gets put on norepinephrine, right? He stays in the ED with long boarding times because that's not just a problem in resource-constrained settings, right? He's in my ED for 16 hours and gets intubated at hour 16 because he has progressive hypoxemic respiratory failure. He's sick, right? But he still has a fair likelihood of survival. We know from lots of RCTs that this is about a 35% mortality condition. If Robert comes to see me in Kigali, I can't speciate his sepsis. My etiologies are broader, and they're more likely to be antibiotic resistant, right? He previously lived in a place that's got a lot of antibiotic-resistant organisms, which is true of a lot of people all over the world. I can track his sepsis resus with POCUS, and I can also track it with some things that are maybe almost as good as these lab tests, like his urine output and his cap refill. He's gonna get the antibiotics that I've got, which in this case are gonna be ceftriaxone and metronidazole, and it's gonna happen 2, maybe 3 hours after ED arrival. He may or may not get pressors depending on what the last shipment of them arrived and what I still have that's good, right? But he's probably gonna get crystalloid resuscitation, and we can talk later or offline about whether that makes sense for him, right? He's not gonna get intubated because he's got financial constraints and I don't have a ventilator free. So as his hypoxemic respiratory failure gets worse, he's gonna have to just chug along. We know from limited studies that he has a pretty poor likelihood of survival. If I intubate him, his likelihood actually probably gets worse. This is a condition that probably has about 85% mortality. Now, what about Faustin? So Faustin works with me. He works at the hospital. He's my people, right? He works as a hospital groundskeeper, and someone said, hey, that wasp nest, it's making us look bad, and a politician is gonna be coming soon, so get that clean, right? So he goes to clean it out, and what happens? He gets attacked by the wasps that he was trying to evict. He presents in clear anaphylactic shock. He's covered in embedded stingers, he's wheezing, he's got diffuse erythroderma, he's tachycardic to the 170s, and I only have centrally palpable pulses, right? All of you have seen a bad anaphylaxis, and it is scary. So he lands in the middle of the night in my emergency department in Baltimore. He's had pre-hospital IM epinephrine. Somebody's gotten a peripheral IV in him, even though he's cardiovascularly collapsed. He lands to my decon room and gets a full decon of stingers. I've got med students, I've got people coming out my ears to help decon him, right? He gets an epi drip mixed in the ED by an ED pharmacist, and it's available a la minute, right? And he gets multimodal prescription treatment for his anaphylactic shock. And then he gets monitored. We watch him for a while. He's got an excellent likelihood of survival. This guy had the scariest event of his life happen today, but he's gonna be fine. In contrast, if he comes to see me in Kigali, he actually might get picked up by the ambulance because the ambulance is on my hospital campus, all right? So he gets driven around the corner. And they probably started a peripheral IV because they're really proud, justifiably so, of their peripheral IV skills. And he gets the main thing that's gonna save his life. He gets IM epinephrine because I reliably have it in stock because it is a WHO critical drug, all right? The resident provider, instead of the ED pharmacist, knows how to mix an epinephrine drip using a donated supply of concentrated epinephrine, which is not on the WHO list, and he gets a full decon of stingers because while I may not have quite as many people, everybody is really invested in saving one of our own, and he gets limited multimodal treatment. This guy also gets monitoring for worsening of his anaphylaxis in the ED, and he can stay for up to 24 hours. He's got a good likelihood of survival, right? He has survived due to these EM systems that may not have been in place in this very same hospital even a couple of years before. I'm running short on time, so I'll leave you with this. Excellent shock care can happen anywhere, but it sometimes looks a little different than you may expect, especially if you've trained in a place that has all of the stuff, all of the staff, all of the systems, all right? The most efficacious critical care is a critical care intervention that your patient never needs, and that's by J.C. Farmer, all right? So some take-home points. Believe your local colleagues about pitfalls while resisting the pull of premature futility. When you seek and respond to resuscitating critical illness with an eye towards incremental gains, where are the little wins that I can achieve here for this patient or the next patient who's like this patient? You really do achieve success. Second, trust in things that can't break or have a plan D or E or F. When you're assessing somebody for septic shock, think about what are the low resource things that I can do to help assess the adequacy of my shock resuscitation. Lastly, don't just fish people out of the river, okay? If it's obvious that every couple days you have somebody floating down the river with critical illness, look upstream and fix why they're falling in. I know I'm wearing my MPH hat when I'm saying this to all of you, but I hope that I can get some of you energized about reframing public health as any intervention that's gonna help 2 or more patients. You'll be astonished by the number of wins that you can identify in your emergency department or emergency departments around the world where you may find yourself working. Thank you guys so much for your time. I'm gonna leave it there and hand over.